Introduction. The word coarctation originated from the Latin coarctere, to contract. A coarctation of aorta is a congenital narrowing of the descending thoracic aorta, usually but not always occurring just distal to the left subclavian artery, adjacent to the site of insertion of the ductus arteriosus, that is ligamentum arteriosum. The occurrence rate is 0.2 to 0.6 per thousand live birth, and the coarctation of the aorta represents 5 to 8% of all cases of congenital heart diseases. It is the eighth most common congenital heart disease. Other associated congenital heart defects include patent ductus arteriosus, bicuspid aortic valve, ventricular septal defect, and mitral valve abnormalities. The presentation varies from cardiovascular collapse in infancy after ductal closure to asymptomatic hypertension in an adult. It was reported as an autopsy finding by Morgagni in 1760. He described a localized constriction of the descending aorta. In 1938, Robert Ross experimented with the repair of coarctation of aorta in animals and documented the possible complication of severe hemorrhage and paraplegia. First successful repair in human was performed in Stockholm, Sweden in 1944 by Clarence Crawford in a 12-year-old boy with severe hypertension. This is a photograph depicting coarctation of aorta. Embryology and anatomy. Bennett suggested dividing patient with coarctation of aorta into two groups, infantile and adult. Infantile later became known as preductal and adult as postductal. In the infantile group, the ductus arteriosus is open and there is a tubular narrowing of the isthmus of the aorta proximal to the ductus. In the adult type of coarctation, the ductus is closed and there is a self-like narrowing within the lumen of the aorta. The key difference here is the patent ductus arteriosus provides blood flow to the lower extremity in the preductal infantile group. The critical factor that determine the hemodynamic burden to the patient are whether the ductus is patent, the size of the transverse arch, and the degree of narrowing at the coarctation site. This is a photograph. Figure A defines infantile or preductal, and figure B is adult or postductal. The classification system proposed by the International Nomenclature and Database Conference for the Pediatric Cardiac Surgery is coarctation of the aorta isolated, coarctation of the aorta with VST, and coarctation of the aorta with complex intracardiac anomaly. Embryology. There are two complementary theories explaining the embryology of coarctation of the aorta, Rudolph's flow theory and Skoda's ductal sling theory. According to the flow theory, which is based on the hypothesis that blood flow through the cardiac chambers and great arteries during fetal life determines their size at birth. This theory holds that coarctation of the aorta forms because of lack of fetal blood flow across the aortic isthmus. The intracardiac defect that could cause the coarctation on the basis of this theory are in fact clinically commonly associated with these patients. It includes VST, bicuspid aortic valve, congenital aortic stenosis, and congenital mitral valve stenosis. The role of the limbus of foramen ovale is to deflect the appropriate portion of the inferior vena cava blood to the ascending aorta. Prenatal narrowing of the foramen ovale or an improper angulation of its limbus can lead to variable degree of hypoplasia of the left-sided structure. This explains the shown complex: coarctation of aorta, parachute mitral valve, supravalvular mitral ring of the left atrium, and subaortic stenosis. Corroborating evidence is the corollary region that reduce right heart output such as tetralogy of Fallot, pulmonary stenosis, and tricuspid atresia are almost never associated with the coarctation. The flow theory, however, is not very convincing for patients with no obvious intracardiac defect. For these patients, the ductal sling theory is more appealing. More than 100 years ago, Skoda postulated that abnormal extensions of the contractile ductal tissues in the aorta is a significant factor in the pathogenesis of coarctation of aorta. Coarctation and fibrosis of this ductal sling at the time of ductal closure would lead to constriction of the aorta and a primary coarctation. This explains the origin of coarctation of aorta, where there is no associated intracardiac lesion. There are other two theories also. Kapteyn and colleagues believes that an abnormality of neural crest development also plays role in the pathogenesis of coarctation of aorta. Another is genetic factor. There is increased incidence of coarctation in female with Turner syndrome, almost around 15 to 16%. Anatomy. The anatomic features of coarctation depend on the age of the patient, whether there is an associated patent ductus arteriosus, the degree of hypoplasia of the transverse aortic arch, and isthmus. Infant with coarctation and with coarct and patent ductus arteriosus, there is a often diffuse narrowing of the aorta distal to the common carotid artery, a large patent ductus arteriosus, almost of the size of the descending aorta, connects the descending aorta to the pulmonary artery. The opened aorta reveals a coarctation membrane proximal to the entrance of the ductus. There is a minimal post-stenotic dilatation of the descending aorta and only minor enlargement of the intercostal arteries. In older adult with a juxtaductal coarctation, there is often a visible external narrowing of the descending aorta at the level of the ligamentum. The degree of external narrowing, however, does not necessarily correlate with the lumen of the aorta, which contain a shelf-like concentric narrowing that may result in a pinpoint lumen. Rarely, there is a complete occlusion of the lumen, and all flow to the descending aorta is from the collateral arteries. The aorta proximal and distal to the coarctation is often dilated with the enlargement of the proximal subclavian arteries. The intercostal vessels entering the descending aorta are large, thin-walled, and may even aneurysmal. The collaterals in coarctation of aorta. When a coarctation is present, there is a progressive enlargement of collateral blood vessels around the coarctation. This collateral flow is predominantly from the subclavian artery and its branches, the internal thoracic, intercostal, scapular, cervical, vertebral, epigastric, and spinal arteries. These vessels enlarge steadily and in older children, more than 4 years of age, and the adult chest radiography show the characteristic rib notching of the inferior aspect of the rib due to the presence of the dilated and tortuous collaterals. These large collateral vessels provide enough flow to the lower body to maintain organ function and growth. The photograph depicting the same collaterals, we can see from the second and third intercostal spaces on the left side, a lot of collaterals are formed. Now there is a term pseudocoarctation of the
You have to
aorta.
know the diagram well, because when you are writing a question in the exam, you have to mention these things.
Okay,
So
sir.
this diagram is very important, especially in a case of coarctation.
Okay, sir. Uh, Another term is pseudocoarctation of aorta, which is a rare condition presumably resulting from a congenital elongation of the aortic arch. The elongation leads to redundancy and kinking of the aorta, which may appear similar to the corked but has no actual obstruction to blood flow. There is usually little or no demonstrable pressure gradient. Because of the tortuous nature of the aorta, however, there is a tendency for dilatation and aneurysm formation, presumably related to turbulent flow across the kink. This patient should be followed closely and surgical intervention may be required if dilation compresses surrounding structures or aneurysm formation is discovered. Coarctation of abdominal aorta occurs only in 0.5 to 2% of all cases of corked and is usually associated with congenital diseases like congenital rubella, Takayasu arthritis, or von Recklinghussen's disease. Diagram depicting the pseudocoarctation. On the natural history and pathophysiology. The presentation of patient with corked of the aorta occurs in bimodal distribution. There is a group that presents in the first few weeks of life whose blood flow to the lower body is dependent on a patent ductus arteriosus. If not diagnosed before ductal closure, they may present in cardiovascular shock. Collateral flow is inadequate in infancy and ischemia of organ distal to coarctation result in renal failure and acidosis. At the same time, there is Sorry. At the same time, sudden increased afterload on the left ventricle results in acute congestive heart failure. The management of these neonate has greatly improved by the introduction of prostaglandin E1, which opens and maintains the patency of the ductus arteriosus. In some patients, PGE1 may not open the patent ductus arteriosus, but it does improve blood flow through the coarctation site by acting on the ductal sling tissues. Surgical intervention can be planned on a semi-elective basis at a time when the function of the various organ system has been optimized. The other arm of this bimodal presentation is a group of patients who are asymptomatic but present with a hypertension on routine physical examination. The main cause of symptom in these patients is the proximal systemic hypertension, which may cause headache or epistaxis. They may also have claudication from inadequate lower extremity perfusion with exercise. Alternation in renal, adrenal, and baroreceptor function all contribute to the development of this proximal systemic hypertension. This also may lead to Circular of Willis aneurysm, aortic aneurysm proximal or distal to the coct, aortic dissection, and increased coronary atherosclerotic heart disease with associated myocardial infarction. The cause of death in unrepaired coct will be congestive heart failure, bacterial endocarditis, or a spontaneous rupture of the aorta and intracranial hemorrhage. Diagnosis: newborn with critical coct and ductal closure will present in shock. On physical examination, the child will be tachypneic and tachycardic and will appear pale. The lower extremity pulses are absent and upper extremity pulses will be thready. The child may be hypotensive even in the arms and liver will be enlarged. Chest X-ray will demonstrate cardiomegaly and evidence of congestive cardiac failure. ECG will show left ventricular strain pattern. In many instances, for newborn infant, a comprehensive echocardiogram is all that is required to prepare a patient for surgical intervention after stabilization of organ system. However, if there is a complex associated cardiac anomalies, cardiac cath can safely be performed in a stable baby who is being maintained on prostaglandin infusion. Chest X-ray depicting infantile cardiomegaly. In older child, often with no symptom, physical examination will reveal upper extremity hypertension and absent or greatly diminished femoral pulses. ECG demonstrate left ventricular hypertrophy and left ventricular strain. Chest X-ray will often demonstrate notching of the rib if the patient is above 4 years of age, and the classic 3 sign on chest radiograph is caused by dilatation of the left subclavian artery, the narrowing of the coarctation site, and post-stenotic dilatation of the descending aorta. Cardiac cath is required for these patients if there is an associated intracardiac anomalies. The presence or absence of collateral is noted to help in predicting the need for left heart bypass. We can see the rib notching here on the inferior aspect of the posterior ribs. The E sign on the esophagogram and the plain chest X-ray demonstrating the classical 3 sign. And MR angiogram showing the collaterals. Now the indication for the surgery. Presence of symptom is an absolute indication for surgery. But if the child is asymptomatic, surgery is indicated if the luminal diameter is less than 50%, hypertension in the upper extremities, a large systolic pressure gradient of more than 20 mmHg between arms and leg, and mild coarctation less than 20 mmHg gradient may be considered for surgery if there is a prominent gradient develops after exercise. Timing for the surgery. With left ventricular dysfunction, congestive heart failure, or severe upper limb hypertension for age, immediate intervention is required. Normal left ventricular function with no congestive heart failure and mild upper limb hypertension, intervention beyond 3 to 6 months of age. No hypertension, no heart failure, normal ventricular function, intervention at 1 to 2 years of age. Intervention is not indicated if Doppler gradient across cox segment is less than 20 mmHg with normal left ventricular function. Surgical management. After anesthetic induction, nasopharyngeal temperature of about 35 degrees Celsius. Blood pressure in right arm is monitored by indwelling radial and brachial femoral artery. Near infrared spectroscopy can be used to monitor tissue oxygenation, both proximal and distal to the coct. Via left posterolateral thoracotomy, via fourth intercostal space, we enter. Mediastinal pleura open and stay sutures placed on edges for exposure. Arteries are dissected in areolar tissue, keeping close to aorta. Now, the procedures which are performed. Resection and end-to-end anastomosis. It was initially described by Crawford and Nylin in 1945. The image depicts the same. Simple resection with end-to-end anastomosis has been essentially abandoned though. The steps were the ductus arteriosus were ligated and divided. Small bulldog clamps placed on third and fourth pairs of intercostal arteries. Proximal clamp is positioned across the aorta and base of subclavian artery to leave ample length for proximal curve. Coarctation is excised, getting back to a wide orifice proximally and distally. And then the running monoflint absorber suture line is begun at far end of the circumference and progresses along posterior aspect of anastomosis. Now, the widely practiced thing is resection with extended end-to-end anastomosis. It was initially done for infants with hypoplastic aortic arch, but is now the procedure of choice. Dissection is carried along proximal aortic arch up to distal ascending aorta. Proximal innominate artery is also defined. The proximal aortic clamp is positioned between the innominate artery and the left carotid artery. The distal vascular clamp is placed below the coarctation. The entire coarctation segment and the ductus is excised. Proximally, an incision is made on the inferior surface of the transverse arch up to the proximal clamp. Distally, the descending aorta is incised laterally in a mirror fashion to the other incision. The anastomosis is then performed with running polypropylene suture. Elliott modified this technique to address transverse arch hypoplasia, utilizing a clamp proximal to occlude the left subclavian artery, the left carotid artery, and even the part of the right innominate artery. This allowed extension of the aortic arch incision more proximally. Thus, the name is radically extended end-to-end anastomosis. Currently, it is a procedure of choice for infant with coarctation. There are several advantages of this technique. All coarctation tissue with uncertain potential for future growth is completely resected. The left subclavian artery is preserved, avoiding potential left arm ischemia or growth disorder. And the procedure addresses and corrects hypoplasia of the transverse arch, distal aortic arch, and the aortic isthmus. The technique avoids prosthetic material, limits the potential for aneurysm formation, and preserves the normal vascular anatomy. The other procedure is prosthetic patch aortoplasty. Bosachult in 1957 described an isthmoplastic procedure that developed into the prosthetic patch aortoplasty. The aorta is incised longitudinally through the site of coarctation, with the incision being extended well beyond the level of coarctation, both distally and proximally. Proximally, this means that the patch often extends up to the left subclavian artery. A circular prosthetic patch, slightly elliptical, made of polytetrafluoroethylene, is sutured in place longitudinally along the iotomy edge. The largest patch visible is used and place the widest portion of the patch at the level of the aortic constriction. The pleura should be closed as completely as possible over the patch. The advantage over simple resection with end-to-end anastomosis is the collateral vessels are all preserved. They do not require ligation and division. The technique allows simultaneous enlargement of the ischemic hypoplasia if necessary. The anastomosis is tension-free, and posterior aortic wall, even a hypoplastic arch, will grow after prosthetic patch repair. But the primary worrisome late complication of this technique is aneurysm. Because of the formation of the posterior aortic wall opposite the patch, because of violation of the intimal layer, and the patch causes altered hemodynamics arising from the different tensile strength of the prosthetic patch and the posterior aortic valve, the pulsatile waveform being completely directed to the posterior aortic valve by the inflexible anterior patch. This is the diagram depicting incision has been made and the PTFE has been cut in the elliptical fashion and then being sutured in the continuous pattern. The other technique is prosthetic interposition graft. The use of prosthetic interposition graft was first described by Robert Gross in 1951 when he used an aortic homograft as a replacement for coct in a child with long narrowed coct segment. Currently only recommended for patients over 10 years of age with an associated aneurysm or complex long segment coct and selected patient with recurrent coarctation. The obvious disadvantage of the graft is the developmental size discrepancy in the growing child, making the operation more applicable for older children. Another consideration is the longer aortic cross clamp time taken to perform two circular anastomosis. This is a diagram depicting the same. The interposition graft has been put after dissecting out the coct segment. The subclavian flap aortoplasty. The subclavian flap aortoplasty technique was introduced by Waldhusen and Nahavold in 1966. Used in neonates when resection anastomosis is not possible. PG1 infusion is maintained throughout procedure. Dissection of the subclavian artery is carried distally to expose the branches. It is ligated and divided proximal to the branches. A longitudinal incision is extended along the full length of the subclavian artery and across the area of coarctation opposite the ductus. The left subclavian patch is turned down and is sutured into aortotomy using a running suture technique. Diagram depicting the same. Then we have reverse subclavian patch aortoplasty used in hypoplasia of the distal aortic arch. It is usually performed in conjunction with resection and end-to-end anastomosis. Incision along the right side of the subclavian artery, the superior surface of the distal aortic arch, and the left side of the origin of the left common carotid artery. Side-biting vascular clamp is placed across proximal aortic arch to include base of left carotid and left subclavian arteries and also aortic isthmus. Left subclavian artery is ligated, opened, and is turned back in a reverse direction as a flap to complement hypoplastic distal arch. Clamp shown in B is removed and replaced by arch clamp. Distal aorta is clamped between the third and fourth set of intercostal vessel, and third set of intercostal vessel is controlled with clips. The ductal arteriosus is ligated and divided, and aortic coarctation resected, and then end-to-end anastomosis is performed. The anterior midline approach, it is only reserved for the patient if there is any associated congenital anomaly and there is a need for going on complete bypass. Balloon dilatation angioplasty. In 1979, Sauce and Associate demonstrated that a surgically resected neonatal aortic coarctation could be successfully enlarged with a balloon dilation catheter. Locke and colleagues performed dilation on 7 resected coct segments and showed that 8 atmospheres of pressure produced considerable increase in internal aortic diameter as a result of linear intimal tearing with medial extension. Marvin and colleagues reported that development of aortic aneurysm near the site of balloon dilation angioplasty for native coarctation. Microscopy revealed disruption of the intima and elastic media, which resulted in thinning of the intact adventitial wall of the vessel. So the balloon angioplasty is the procedure of choice only for recurrent coarctation of the aorta following surgical repair. The fibrous perivascular post-surgical scar appears to allow safe use of this technique for recoct in contrast to the danger of aneurysm formation when balloon dilatation is used for native coarctation of the aorta. Immediate post-repair management. Distal clamp is removed first. After the proximal clamp has been slowly opened, great care is taken to maintain proper ventilation and baseline systemic blood pressure for at least the next 5 minutes as a precaution against sudden development of intractable VF 3 to 4 minutes after the release of the clamp, declamping syndrome. Sodium bicarbonate or an infusion of pure peripheral vasoconstriction just before the clamp removal in particularly unstable infant or those with prolonged clamp type, and systolic gradient of more than 10 mmHg in a re-repair done. If systolic gradient is more than 10 mmHg, re-repair is done. Post-op care, managing systemic arterial hypertension. Older patient, mean arterial blood pressure at 110 mmHg with nitroprusside for the first 24 hours, and the drug is then rapidly tapered and discontinued. Thereafter, if BP is more than 150 mmHg or beta blocking agent or captopril is administered for a few weeks. Abdominal pain post-coccectomy syndrome. Mild abdominal discomfort for a few post-op days. 5 to 10% is there. Abdominal distension with hypoactive bowel sound may develop. Treatment consists of bowel decompression via nasogastric tube and antihypertensive drug. The protocol which we follow in NH, on an average, we do 10 cases of coarctation of aorta in a month. The anesthesia technique is both radial and femoral arterial lines are put. General anesthesia along with intervertebral block is given. Lately, they have started doing this and has been proven effective in managing post-operative hypertension. And in some instances, a sprinkling of bupivacaine on the anastomotic side. I asked the anesthetist, sir. They were telling that there is no need of giving soda bicarb after post-op because on serial ABGs they have never found acidosis, so it is not followed in our center. Approach: we go by left postolateral thoracotomy. Procedure: extended resection and end-to-end anastomosis mostly. Only in patient with associated intracardiac lesion we go via midline approach on CPV. Post-operatively, patient still has hypertension, IV milrinone or GTN is started to offload the heart. Never they have started nitroglyceride. Patient is only kept NPO for 24 hours. Complication: potential complications of surgery: recoarctation, paradoxical hypertension, paraplegia, recurrent laryngeal nerve injury, left arm ischemia, hemorrhage, aneurysm formation, chylothorax, Horner syndrome, phrenic nerve injury, or cerebrovascular accident. Hemorrhage: even though none of the techniques utilized requires intravenous heparin, except if cardiopulmonary bypass is used, the suture lines nearly always have an initial moderate degree of bleeding until clots form within the needle holes. At termination of the procedure, chest tube should be placed in position to monitor and evacuate post-operative blood loss. Any sudden increase in the amount of bleeding from the chest tube should result in patient's immediate return to the operating room for control of bleeding. Paradoxical postoperative hypertension. The etiology of the postoperative hypertension is felt to occur secondary to two hypertensive responses. The first response occurs immediately and subsides in most patients within 24 hours and is due to the release of the stretch on the baroreceptors in the carotid artery and the aortic arch after removal of the aortic obstruction. This increase in blood pressure occurs until the baroreceptors are set at a lower level. The best evidence for this is the marked increase in sympathetic activity indicated by elevation in norepinephrine level after operation. This occurs in slightly over half of patients and in most cases subsides within 24 hours. The second phase, which is more pronounced in diastole, appears within 48 to 72 hours and occur in about one-third of those experiencing the first phase of hypertension. It is associated with elevated level of renin and angiotensin, which may be stimulated by the first phase of paradoxical hypertension. The second response may be adaptation gone awry that ensures adequate flow to exercising muscles below the coct above and beyond delivered by increasing the systolic pressure. Unchecked hypertension in post-op phase can have disastrous result because the mesenteric arteries have been accustomed to a very low blood pressure. The sudden increase of arterial pressure in these arterioles may lead to severe reactive acute inflammatory changes. This may result in mesenteric arthritis and subsequent evolution to mesenteric ischemia. The child then develops severe abdominal pain, distension, and tenderness. On association, this will cause gastrointestinal bleeding and may require laparotomy with bowel resection. This post of hypertension must be very carefully monitored and managed because of the risk of mesenteric arthritis and patients are kept NPO for first 24 to 36 hours following coct repair. The tendency to have persistence of the hypertension late after coarctation repair is proportional to the age of the child at the time of the operative repair. All patients of the COX should have lifetime follow-up by a cardiologist. Warner's and colleagues have made the point that coarctation should be regarded not as a localized abnormality, but as a diffuse arteriopathy deserving long-term follow-up. The next treated complication is paraplegia, which was first reported by Gross and Hufnagel as a possible complication in animals following coarctation repair, and to this day remains a serious and feared complication. Paraplegia correlated with the length of aortic cross-clamping. Mean cross-clamp time in those patients with paraplegia was 49 minutes, and the presence of aberrant origin of the right subclavian artery below the coarctation. So, to avoid the paraplegia, it is recommended that cross clamp time should be as short as possible and careful technical anastomosis so that there should not be any reapplication needed. Moderate hypothermia, 34 to 35 degrees Celsius, and high proximal blood pressure, no acidosis, and adequate distal mean blood pressure of more than mean should be more than a 45, the most important. The next is aneurysm formation. Both true and false aneurysm have been reported as a complication after all types of cock repair, though more reports of true aneurysm formation following prosthetic patch aortoplasty than any other technique. The reason for aneurysm formation was that part of the circumference of the aorta was replaced by a material with tensile characteristics differing from those of the aorta itself. Transverse arch hypoplasia also predisposes to aneurysm formation. The risk of aneurysm formation appears to be higher for patient having a patch at 16 years of age or operated or as a recoarctation following resection with end-to-end anastomosis. The incidence of aneurysm formation also appears to be significantly higher after Decaron patch as compared to PTFE patch. Recoarctation and repair. Recoarctation is defined as a postoperative arm-to-leg peak systolic pressure gradient exceeding 20 mmHg across the repaired area. Magnetic resonance imaging, distal subtraction angiography, and bicycle exercise testing are useful in detecting residual coarctation of aorta. Resection and end-to-end anastomosis had a recoarctation rate. This was probably secondary to the use of silk suture instead of currently available fine monofilament suture. Inadequate resection of all ductal tissue that may extend into areas of normal appearing aorta, lack of growth at a circumferential suture line, and lack of growth of a hypoplastic transverse arch. The subclavian flap iotoplasty, although originally felt to nearly eliminate recoarctation, definitely has a rate of recoarctation higher than initially thought, 13%. The patch iotoplasty should not be used in infant because of the high recoarctation rate. Resection with end-to-end anastomosis appear to have lowest recoarctation rate, 6%. Balloon angioplasty is now considered the initial procedure of child with most procedure of choice for most children with recurrent coarctation of the aorta. Thank you.
Okay, thank you, Divyanshi. But I find there was little bit of incompleteness in your presentation, although it was good. Now, a few things, the comments I would like to make. When you're approaching a coarctation through a posterolateral thoracotomy through the fourth space, after you incise the mediastinal pleura, it is always safer to loop all the arteries, subclavian, the distal arch, and the
Yes.
descending aorta, would
Okay,
loop
sir.
them and keep them for safety purposes. Because if there is a problem, you can always retract that and put a clamp across. So this is very important, and especially for junior surgeons and when you are starting your career. Next, I'm not too sure about heparin. We were always told that, you know, anytime you clamp an artery for more than 5 minutes, we would give heparin because the clots formation would be there. That used to be the norm in our days, but I don't know whether there is any change now.
So in our
Then,
institute, we are still giving heparin, sir, after cross clamp, but this was
yes,
mentioned in the textbook, so I wrote in the slide, sir.
okay, but you stick to what we form in our in print. Better to be safe than sorry.
Okay, sir.
Okay.
Yes, sir.
Then the Washulte Dacron diamond patch. It was not a circular patch. It was initially used as a diamond patch. You know,
Yes.
the vertical incision across the coarctate segment, and then you retract the aortic wall at the area of maximum narrowing, and then put a diamond patch. And this is more or less given up for all the reasons that you already said. And initially, people did a lot of these repairs, Washulte repairs, because it was the simplest and most easy to do. But then they realized that there was a saccular aneurysm on the posterior wall, and that then it was given up. Now you came to the next thing that you came to was the anterior approach. I wish you had elaborated on that anterior approach, because VSD coact is a very common combination. And in the olden days, we used to do them as stage procedures. Okay, the
Yes,
dictum
sir.
in those days was to repair the distal lesion first, and then go to the proximal lesion in the heart. So
Yes, sir.
we always used to do coact repair, and then subsequently as a second sitting go into, or maybe in the same sitting you have to turn the patient, go midline, and then do it.
Yes, sir.
Nowadays they do the both the things in the same sitting. And I wish you had elaborated a little bit about the technique about that, and then the timing, how it is done, because nowadays they don't do a stage procedure, I'm told. Then the other thing was about the complications that you talked about.
Yes, sir.
The landmark article you all must read is the Brewer's article, which quoted more than 13,000 patients in the early 1980s, and that is a landmark article because that was one of the largest series of coarctation that was published. And the this thing about uh, paraplegia. Paraplegia
Yes,
is the
sir.
one thing that it's a dreaded complication that you have to make sure that the artery of Adamkiewicz is maintained or perfused. Some people also use some amount of cold saline flush in the chest cavity, or even if it is very severe, they have used a left heart bypass as well. So these are important things that to prevent paraplegia, because paraplegia is a dreaded complication after coact repair.
Yes, sir.
And lastly, I think you should know what are the surgical options for recoact. Okay, so
Okay.
if you have a recoact, and why when it happens, apart from balloon dilatation, there are various other surgical options necessary, and those should be you should be aware of those things. All right.
Yes, sir.
So mm, I think these are the main things that I could come across, uh, and sir will have a little more things to add to it. So
Yes, sir.
It is a good presentation, but only thing, as we always say, always you start with the incidents and the natural history of these things. Incidents, of course, you said forms about 6 to 8% of all congenital heart disease. And the previous classification of infantile and adult, most people nowadays think that most of the Caucasian uh, has a ductor. It's not either pre-ductor or post-ductor. The other thing is that should have discussed little more of how neonate present, because the normal physiological closure of the ductus occurs between 10 and 14 hours after birth. So in a patient with what you call infantile or pre-ductal coarctation, when the ductus starts closing, they present with severe hemodynamic collapse
Yes, sir.
because the lower body doesn't get any blood, anuria, severe acidosis, and severe hemodynamic collapse. That's how they present. So that presentation, that means those they need immediate surgery. Immediate surgery means you resuscitate them, as you said, with prostaglandins and try to get some blood into the lower part of the body. Correct the acidosis. As soon as they are suitable, take for surgery.
Yes, sir.
Today, the cardiologist opinion all over India, they said that the child is very sick, you can do arthroplasty, coarctoplasty,